Okay, thank you so much for joining us for our webinar today. B. infantis EVC001 is well tolerated and improves human milk oligosaccharide utilization in preterm infants in the neonatal intensive care unit. My name is Megan Landrum. I am a registered pediatric dietitian and I lead medical communications and education for Evolve Biosystems, the parent company of Evivo, and I am pleased to introduce our two speakers for today's presentation. First, Dr. Carl Sylvester from Stanford University. Dr. Sylvester specializes in clinical pediatric fetal and neonatal surgery, and he is a leading expert in necrotizing enterocolitis. Dr. Sylvester is the co-director of the Stanford Metabolic Health Center and the Associate Dean of Maternal and Child Health Research at Stanford. Also joining us today is Dr. Sarah Bajorek. Dr. Bajorek completed her training at the University of Florida, where she worked with Dr. Joseph New to study the neonatal gut microbiome and worked on the clinical nutrition team to standardize and improve nutritional practices in the NICU. Dr. Bajorek then practiced at Orlando Health Winnie Palmer Hospital, where she completed the study to be discussed during today's webinar. She has since relocated and is practicing at St. Mary's Hospital in Colorado. Before handing it over to our speakers, I'll provide an overview for today's discussion. When it comes to probiotic use in the NICU, expert groups have previously suggested a rigorous clinically tested approach. And a growing body of evidence supports the use of a targeted single-strain probiotic, B. infantis EVC001, due to its unique mechanism of action to fully utilize specific components of human milk. NICUs looking to maximize the benefit of human milk feeding protocols may consider a nutritional approach to probiotic use that allows for a more overall improvement of infant health in the NICU. So today we will review a recently published study aimed to evaluate the tolerability, HMO utilization, and effects on the fecal microbiota of B. infantis EVC001 in preterm infants at Orlando Health Winnie Palmer Hospital. I will now turn it over to Dr. Sylvester.
Thanks, Megan. Really appreciate the opportunity to speak briefly this afternoon about a topic that I've really become quite passionate around. And the reasons for that is it's really mirrors my longstanding interest in newborn gut health and my clinical experience of having, unfortunately, to experience babies with necrotizing enterocolitis, beginning with my training. And ever since that time, I've, like many of you, believed there had to be a better way. And thankfully, I believe that a product like EVC001 and the science and biology behind it really actually elegantly explains some of the more common problems we see and potentially even might explain and prevent long-term necrotizing enterocolitis. So let's jump into some slides, because really my focal charge here this afternoon is really to just lay some groundwork and some scientific rationale for the clinical study that Dr. Bajorek is going to present. And that is, we're going to be talking about a stabilized neonatal gut. And to get to a gut that really is meant to provide the greatest amount of health and avoidance of disease to a baby requires two key ingredients. The first of which is depicted on the left-hand side of the slide, and that is to be seeded with bacteria. And historically, and still to this day, that occurs during birth, seeding through passage of the birth canal and by the bacteria that are present on mom's perineum and ultimately by her skin. And a particular taxa of bacteria known as Bifidobacteriaceae and one particular strain, Bifidobacterium infantis, unfortunately has gone extinct. And these bacteria are no longer vertically transferred from mom to baby because of modern medical practices, including C-sections. So you bypass that route and the extensive use of perinatal antibiotics. Moreover, this bug actually evolved to pair with breastfeeding because that was the only source of nutrition for most newborns for 6 months to 2 years of life. And importantly, a portion of breast milk that's known as HMOs, that's human milk oligosaccharides, has of increasing interest, of course, in newborn nutrition. But what we need to understand is actually that HMOs themselves, which is 15% of the dry weight of breast milk, is not nutrition for baby. It's actually nutrition and substrate and carbon source for bacteria. So here you have an experiment of nature whereby mom produces 15% by dry weight of breast milk to select a bacterium. And in this case, there's very few taxa, and in this case only Bifidobacterium infantis, has the full complement of the genetic and enzymatic repertoire to completely digest that HMO. So a beautiful relationship that has been disrupted. And therefore, most of our newborns, both those who are hospitalized as well as those who are ambulatory and otherwise well-term babies, don't have this relationship, and as a result have a inflamed gut, many times subclinically, but also perhaps overtly. They don't have a barrier function. They don't have proper priming of the immune system, which can lead to both short and long-term problems. And they're not experiencing the full metabolic benefit of breastfeeding because after the HMO is broken down, which is feeding the bacterium, additional nutritional benefit is provided to baby. Now, all this has potentially changed because of a fantastic discovery out of the University of California, Davis, that really unraveled a lot of this and identified this particular species, and we'll call it the infantis henceforth, that really had evolved with baby, but had again disappeared until resurfaced by this group as having the full capacity to mobilize these benefits. So let's examine this a little bit further in the next slide. So when we say, what is the capability in this little bifid or kind of two-pronged bacteria is depicted in the cartoon on the right, has three capabilities, which we commonly refer to as the 3 Cs. It captures these HMOs, which again are different monosaccharides that have these glycosidic linkages, and those cannot be broken down by human babies. So you really require the bacteria, and this bacteria is particularly suited to that. The green Pac-Man that doesn't yet have its mouth open is an AVC transporter. That's how these carbohydrates are captured and brought inside the cell, where they're digested by the open mouth Pac-Man, if you will, in the green. And then the monosaccharides in the form of short chain fatty acids and others, like most predominantly lactate and acetate, are then extruded outside the bacterium because they're just really digesting, but not actually consuming the lactate and acetate, which then is available to babies, enterocytes, and gastrointestinal mucosa, providing additional benefits from an inflammatory and a barrier standpoint. So this particular strain, EVC001, the unique genes and metabolic capacity to capture, to consume, and to convert all this HMO to not only fulfill that symbiotic relationship, but then again, return the maximum benefit to baby. Next slide, please. So let's contrast that, what happens today in the absence of this really beneficial relationship. And that is many papers, including several by myself in collaboration with the company, have demonstrated that the vast majority of babies, term as well as hospitalized, don't have this relationship. Rather, they have an abundance of taxa from Enterobacteriaceae family. And those are your E. coli, your Klebsiella, and your Enterobacter cloacae that have been identified with not only gut inflammation, but also precede the onset of necrotizing enterocolitis in the worst case scenario. And so even though they themselves may not be pathogens, they're potential pathogens, and they cause this subclinical instability and inflammation that's ongoing. So there's erosion of the barrier, there's improper priming of the immune system. And on the right-hand side, they don't consume the HMOs. So since there's no room and no presence for bifidobacterium, and Enterobacteriaceae are thriving. And by the way, they come back after a course of antibiotics. So after antibiotics, the Enterobacteriaceae come back and they flourish once again. HMOs pass through the gastrointestinal tract and are passed out in the diaper as waste products. So 15% of the breast milk that was intended for the bug and an ultimate benefit for the baby is lost. Sometimes this presents itself as diaper rash because the pH is actually very alkaline, which is erosive and caustic to the baby's newborn skin around the perineum, and possibly diarrhea, since you don't have that well-formed stool because of the digestion of this fiber. So this we call gut inflammation and instability, contrasted with gut stability when you have the bifidobacteriaceae present with breastfeeding and HMO. So strategies to stabilize and support this overall relationship are being developed. And in this case, EVC001 as an available product for babies both hospitalized in the NICU as well as term well babies is available. And further evidence to how this relationship works in the NICU is going to be presented by Dr. Bajorek. Sarah.
Thank you so much, Dr. Sylvester. I'm really pleased to be here today. And after completing my research with Dr. New and fellowship, really going deeply into the microbiome, I was really excited to be able to work on introducing a probiotic, introducing EVC001 into the large level 4 NICU. And so I'm really excited to share with you some of the research done by others, as well as the foundation study that I worked on and was just published. So first, we're going to go through an open label observational trial of EVC001 in preterm infants. And this was published in the Frontiers in Pediatrics in 2021. I may refer to this as the NUEN study. So this study enrolled 31 preterm infants born between 24 to 32 weeks to receive EVC001, as well as 46 preterm infants born after 32 weeks in the control group. The infants received EVC001 once daily, along with human milk until they reached 34 weeks, corrected gestational age. Fecal samples were then collected twice weekly during their NICU stay. Next slide. So when the infants from these two groups were compared, they found improved human milk utilization in the infants who received EVC001. The infants in the control group were found to simply excrete these human milk oligosaccharides into their stool instead of breaking them down and utilizing them. You can see on the right, the infants who received EVC001 were in light green versus the infants in the control group were in gray. Basically the infants who did not receive EVC001 just excreted them straight into their stool. Next slide. So this is a really important slide. This slide evaluates the microbiome of the babies in this study. So on the top graph, you will see the relative abundance of bacteria in the control group. And the bottom graph shows the relative abundance of the taxa of the most abundant taxa of bacteria in the group that was fed EVC001. So I want you to first focus on the red and blue bars. The red bars represent the taxa Enterobacteriaceae. And as Dr. Sylvester pointed out, it's well known to cause pathogenicity in preterm infants. And just to review, Enterobacteriaceae includes bacteria such as E. coli, Salmonella, and Shigella. The blue bars represent Bifidobacteriaceae, the taxa that includes B. infantis EVC001. And so you can see that, even upon admission, the infants in the NICU, the most predominant taxa present, especially in the very preterm infants, is Enterobacteriaceae. So it is already colonized. And you can see that there really isn't any Bifidobacteriaceae or B. infantis EVC001 in the bottom bar in the first week. And then obviously once they start to feed EVC001, the relative abundance of Bifidobacteriaceae increases. And as you would expect, the top group, the control group, really didn't have much Bifidobacteriaceae present at all in their microbiome. What's really interesting and very important about this graph is to note that on the bottom graph, the infants who were fed B. infantis EVC001, they were no longer fed or given any EVC001 after 34 weeks. And you can see that B. infantis, or the Bifidobacteriaceae, continued to be the most abundant taxa in their microbiome, and it actually continued to increase in abundance even after discontinuing or no longer providing the probiotic. This is really unique. Other probiotic studies really have not shown this. Typically, once you stop giving the probiotic, the relative abundance declines, and it's no longer the most prevalent bacteria in their gut. And so this is really exciting. And I think it's really important to note that it seems to really crowd out the pathogenic bacteria Enterobacteriaceae. Go ahead and you can move on to the next slide. So we know that Enterobacteriaceae is pro-inflammatory in the neonatal gut. And this slide shows that feeding infants B. infantis EVC001 significantly reduces gut inflammation. So the following markers, calprotectin, IL-4, 5, 8, IL-17A, and TNF-alpha, those are all common and pro-inflammatory cytokines that have been associated with necrotizing enterocolitis, increased permeability, and late onset sepsis. And you can see the infants in green who were fed EVC001 showed between a 1.5 to 3.4 fold reduction in the level of these inflammatory markers. And so this is yet more evidence that EVC001 promotes gut health and doesn't lead to any inflammation and decreases, the distance and the tight junctions and things in the gut. And so this is further evidence that Bifidobacteriaceae is protective for the neonatal gut. Go ahead and move on to the next slide. So as neonatologists, we know how devastating necrotizing enterocolitis and sepsis can be in our population of patients. Reducing these devastating diseases is important and drives a lot of research and resources. We have a short window of opportunity to prevent severe dysbiosis in the neonatal gut, and EVC001 promotes gut health, decreases inflammation, and decreases intestinal permeability. Based on the microbiome results that we've already discussed, even after discontinuing supplementation of the Bifidobacteriaceae, B. infantis, EVC001, it continued to remain an abundant and the predominant taxa of bacteria in these babies, and it continued to proliferate. We know that gut dysbiosis and inflammation can lead to long-term health complications such as atopy, allergies, obesity, and diabetes. It is because of this that we believe that EVC001 can lead to continued gut health and really has the potential for improving long-term health outcomes. This is really exciting and a unique opportunity for us as neonatologists to be able to influence our patients' health long after they've left the NICU. You can go ahead and move on to the next slide. So we're now going to discuss the study that I worked on that was recently published in the Frontiers in Pediatrics last month in January, and it's called the Foundation Study. You can go ahead and move on to the next slide. So the last study that we discussed was an observational study. We wanted to try to have a prospective study in our large level 4 that had never introduced probiotics before. You really can't do a randomized control trial for probiotics. Once you've introduced probiotics into a NICU, you can get something called drift, whereas if a baby receives the probiotic, it's possible that if it got onto a glove or in the air, that it could potentially drift to another baby in the NICU. And so the study was not a randomized control trial. We took the control group of 15 patients, and we fully went through the control group, finished that before ever introducing the B. infantis EVC001 to try to prevent having any drift in the NICU, just to make sure that the data was really pure. You can go ahead and move on to the next slide. So during their stay, we collected several stool samples at baseline, at day 14, and at day 28. So this slide shows that at baseline, there was no B. infantis present in any infants in the NICU, which is what you would hope to see and expect. And then at days 14 and 28, the levels of B. infantis were very abundant in the EVC001 fed group and continued to not be present in the infants in the cohort that did not receive any probiotic. You can go ahead and move on to the next slide. So this slide compares the relative abundance of Bifidobacteriaceae compared to the pathogenic Enterobacteriaceae in infants in the study. We found that infants who had more Bifidobacteriaceae had less of the pathogenic bacteria Enterobacteriaceae, which led us to believe that Bifidobacteriaceae can crowd out the pathogenic bacteria Enterobacteriaceae. You can move on to the next slide. Similar to the Nguyen paper, we found that high levels of human milk oligosaccharides in the stools of the babies in the control group. The babies who received EVC001 broke down and were able to utilize the human milk oligosaccharides instead of releasing them into the stool. The babies in the gray bar graphs show the levels of HMOs in the stools of the control group. And as you can see, the green bars, which are somewhat difficult to see because they're so small, it really shows that the human milk oligosaccharides were really completely broken down. There really was nothing left of the human milk oligosaccharides in the stools of the infants who received EVC001. Go ahead, you can move on to the next slide. So we also looked at the abundance of human milk oligosaccharide utilization genes in the stool samples of both groups. On the left, you'll see the heat map of the genes, the human milk HMO utilization genes in the control group, and then that's compared to the infants in the EVC001 fed group. And so as you would expect, the infants who received EVC001 had a higher amount of HMO utilization genes. And so this is demonstrated by the bright yellow and green marks on the heat map on the right. You can move on to the next slide. Because the babies in the control group were unable to break down and utilize the HMOs compared to the infants in the EVC001 group, it is not surprising that the infants in the control group had really an excessive number of stools compared to the infants who were fed EVC001. So they had about 4.5 stools a day compared to approximately 2. As neonatologists, we know that as infants, start to break down and absorb more nutrients, they stool fewer times a day. And so this correlates with, the fact that we found that the infants fed EVC001 were able to break down the HMOs and actually utilize them instead of just stooling them out. It's also important to note that the infants fed EVC001 didn't become constipated, so they didn't need to have more glycerin suppositories or anything like that, but they just didn't stool quite as excessively as the infants in the control group. You can move on to the next slide, please. So in this study, the foundation study, we found that the infants who received EVC001 had better utilization of human milk oligosaccharides, which we believe led to improved nutrition and normalized stooling patterns. We also found that the group who received Evivo had less abundant Enterobacteriaceae, which is a taxa well known to cause inflammation and is associated with necrotizing enterocolitis as well as late onset sepsis. And we also found that Evivo was well tolerated in our preterm infants, and we had no adverse events in the infants who received EVC001. The table that showed all of this was a little bit busy for the slide, but if you're interested, I'm more than happy to share that with you, or we can send it at the end of this talk. So we can go ahead and basically just summarize that the infants who received Evivo in our unit really did very well, didn't have any adverse events, and we believe they had better nutrition because we fed them EVC001. So I'm going to go ahead and turn it over to you, Megan. Thanks again so much.
Thank you, Dr. Bajorek. So before we wrap up, I'm just going to briefly discuss implementation of B. infantis EVC001, or the product name Evivo with MCT oil in the NICU. Evivo with MCT oil is packaged in quality controlled single serve vials, as you'll see pictured here. Each vial contains 8 billion CFU of activated B. infantis EVC001, and that's suspended in a 0.5 ml serving of MCT oil. Administration of Evivo with MCT oil is recommended once daily and can start as early as with trophic feeds. When it comes to manufacturing quality and safety, Evivo really is developed with your most vulnerable NICU patients in mind. We manufacture Evivo in partnership with Afton Scientific, who is a producer of sterile injectables for the pharmaceutical industry. B. infantis EVC001, the actual bacteria itself, is milled to a size that allows the product to flow through feeding tubes, those really small feeding tubes you're using in the NICU, and enables that low volume administration that you can't get when reconstituting a powder. Every batch and raw materials are tested for quality and safety, and a certificate of conformance can be provided upon request. Evivo is also protected by an entirely cold supply chain with stability and shelf life testing to ensure 8 billion CFU per serving when you're giving that to your patient. And since Evivo is a food for special dietary use and not a dietary supplement, it is regulated by the FDA under the Food Safety Modernization Act, which is a differentiator for Evivo from other products that you may consider for your unit. Thank you so much for your participation today, and we will open it up for questions which can be directed through the chat.
Again, while we're waiting for folks to maybe pose questions, maybe I'll actually both pose and answer a question and ask Dr. Bajorek to reflect on it.
Sounds
And that
good.
is, many times we hear, including in my unit and practitioners that I speak to, is, if this sounds great, but this is a single strain. What about multi-strain formulations that where other products might claim that there's a benefit? And I think the answer to that question is, well, it depends. I think you have to ask yourself, if you're going to choose a multi-strain product, what's the evidence that each of those strains is doing something distinctly beneficial or has an effect? What's its mechanism? What's its biology? I think pretty clearly in the case of EVC001, the data is pretty compelling and continues to grow that it does, again, have this biologic benefit pairing with HMO and breast milk, and then having the secondary effects of displacing the potential pathogens. If you're going to add secondary and tertiary strains, then what's the true benefit to that? And the way I like to think of it is do you need to take Advil, Motrin, and Tylenol all simultaneously if they're more or less just one is doing what you really need, and that is perhaps, in that case, a arachidonic acid or COX-2 inhibitor. But in this case, if you're going to be looking at other products, just like you would with anything we would feed to these precious babies, is just ask yourself what's known about its mechanism of action and how does it actually benefit the baby?
Yeah, I agree. Some of the probiotics that have been given to infants are, commonly found in chickens and things like that. I think that the history of how EVC001 came about, that it was, found in infants in other countries, really shows that at one point it was commonly found in all infants. And so I think that, you start with, it has historically been found in infants and in countries where infants and mothers are not given peripartum antibiotics. It is still found commonly in their gut. So that, first shows, yeah, it is there and it should be there. And then you add more evidence that it fully uses HMOs, it fully utilizes them, whereas other probiotics do not do that. And then you add more evidence that it reduces inflammation and crowds out pathogenic bacteria. I think there's EVC001 has so much evidence that it's supposed to be there and that it is beneficial. I agree that one of the issues with probiotic research is that, studies are sort of jammed together and data is not as pure because, different bacteria are all added together. That I think that Evivo really, of all the probiotics, shows the most potential and benefit because it's supposed to be there in it and really has pure scientific data behind it. So I agree.
I've got a couple other questions here. Dr. Bajorek, when did you begin feeding Evivo and how long should providers provide the intervention in the NICU?
Yeah, so we started providing it to our patients in our study, by the time they got to full feeds. And partially that was to make sure that we had time to enroll the families and they had time to think about whether they wanted to be a part of the study. But as you can see, or if you remember from our graphs, the infants are already, well, from the Nguyen paper, the infants are already colonized with pathogenic bacteria. They're already, just coming into the NICU, they're exposed to abnormal and pathogenic bacteria. And so the sooner you can start it, the better. You may want to make sure that you can start feeds, but you can start it as soon as they get into the NICU. And so I think, yes, because we have pathogenic bacteria in the NICU, you potentially want to try to start crowding out the Enterobacteriaceae and providing the beneficial bacteria that should be there as soon as possible.
Thank you. Does pharmacy handle the product in the NICU where the study was performed, Dr. Bajorek?
Yes, the pharmacy handled, it came from the Pyxis. The pharmacy was involved. And because of how it was formulated, the pharmacy was very comfortable doing that. And then the nurses were able to get it out and mix it and be able to mix it, open it, and to give it to the infants through their feeding tubes.
Great. And I'll just speak on behalf of Evivo that there are units across the country using the product in the NICU, and does not always go through pharmacy, but certainly works well through that route.
I think the other, sorry, one more thing. The other important thing to note is that it does come in liquid form, where many NICUs are moving away from having any powders in the NICU, and so Evivo is in liquid form, whereas a lot of other probiotics that you find are in powder form. So
yeah, that's a great point, and kind of springboards into a few of the other questions we've gotten. One was, do you have a product for use in babies at home? The answer to that is yes. The product for babies at home is in a different format, not as appropriate for the NICU. It's in powder sachets. Another question was, do you have a discharge product? So many NICUs that utilize the MCT oil product in the unit will discharge home. And certainly we can set you up with discharge protocols for doing that and sending your patients home on a product for at-home use. There's also questions that I'll ask you, Dr. Sylvester and Dr. Bajorek, to address. What are the benefits to full-term infants, and should this be given immediately at birth? So we've heard the NICU perspective, Dr. Bajorek. So any thoughts on full-term use?
Yeah, you know, term babies, if they're admitted to the NICU, they're exposed to potentially pathogenic bacteria. Infants who receive antibiotics will be colonized with pathogenic bacteria. Our hospitals, even the newborn nurseries, are colonized with pathogenic bacteria. And so, you know, with the rise of C-sections, we know that those babies are not colonized with quote unquote normal microbiomes at birth. And so really in our culture where we do use more antibiotics, we have more interventions, to even term babies can benefit from receiving Evivo. I can speak from personal experience on this. Our third son was born. He at, several, maybe 2-3 weeks of life, was just grunting and groaning and fussy and, doing the things that we expect healthy term babies to do, but he was becoming progressively more fussy. And so we went ahead and we gave him Evivo. And, not wanting to be biased, I asked my husband, 24 hours later, what do you think? Have you seen a difference? And he was really impressed. And so was I, that within 24 hours, he had gone from being uncomfortable, having lots of gas, crying a lot, to, being much more comfortable. And so we continued Evivo with him, and I was really impressed. I didn't want there to be any kind of bias or anything, but it was good to see how it worked in my own child.
And it's worth building off of that we do have published data in term newborns through a consumer survey, parent reported resolution of symptoms from colic, gas, sleep, fussiness to within 1 to 2 weeks of giving Evivo to the baby. So we have a whole suite of data in the term infant population as well.
I would add to that, Megan, that there's a question, I think, in the Q&A as well, any studies in term newborns, but again, from the biologic perspective, we published a paper, Evolve and myself, in Scientific Reports in January of 2021 that showed the vast majority of infants, several hundred that were sampled term babies across the United States, was on the average prevalence or presence of Bifidobacteriaceae was less than 20%. And again, you saw the red bars that Dr. Bajorek showed was the vast majority. So even our term babies, because of this failure to vertically transfer and the exposure to antibiotics, even if you're not hospitalized, is so prevalent, Enterobacteriaceae are predominant. And then similarly, the follow-on studies, which Megan has spoken to, is around the clinical observations. There's also papers demonstrating that you get this shift, you get the suppression of Enterobacteriaceae in term babies when fed B. infantis, and you get an abundance of B. infantis specifically because it really just pairs and then displaces everybody else. So the same type of phenomenon that we just now presented in the preterm NICU hospitalized baby is true of the term baby. It's just a matter of degree. There's another question. I don't know if you all are seeing this. There's in the Q&A, I'm seeing studies, and Mark Greenfield is asking now, any studies on the long-term benefits?
Thank you, Dr. Sylvester. There are a couple of questions about.
Yeah, there's more questions in the Q&A. I don't know if you're seeing those, Megan.
Yeah, sorry, I think I just had a spotty connection there, which is just the virtual world we live in. But go ahead and address the questions you wanted to, Dr. Sylvester, and then I can address a couple as well.
Great. Now I'm getting your spotty connection. But so the question from Mark Greenfield in the Q&A is, any studies on long-term benefits from Evivo? Any data on growth and development? Great question. Those are coming. So again, building mechanistically on the benefits, I could point you to two papers, one by the Evivo group with the Karolinska, which was in the Cell last June, and a paper that almost came out at the same time from, I think it was a Belgian group and an author by the name of Larson. That group studied Bifidobacteriaceae, but not necessarily EVC001. And the net of those studies is that they show the benefits on the immune system priming in different cell subsets and the degree of inflammation and tolerance, meaning responsive to various pathogens, and really just a lot of great science there. As far as, so we don't have the data yet on long-term, but the data on how does this affect baby's growth is forthcoming. The data on how does this affect other things like perhaps neurodevelopment, or as I think Dr. Bajorek alluded to, if you're affecting the immune system and inflammation at this very critical point, is this going to suppress, as many people have hypothesized, and we tend to believe also, of atopic disease march, beginning with atopic dermatitis and proceeding on through asthma. So the science is there, the hypotheses are substantiated by the biologic findings, the long-term outcomes are emerging.
Thank you. There's questions on product shipping viability that I'll address quickly if my connection is back. Can you confirm?
Yes.
Yes. Okay, great. So yes, product is cold shipped, so entirely cold supply chain. Once the product is open, you want to feed that within an hour of opening the vial, and you store it cold, either in the pharmacy, and then it can come up to the unit and be stored in the Pyxis cold as well.
Megan, question for you from Heidi Lehman in the chat. How familiar are pediatricians with product? And if they're not, who can we direct them to, or parents can get the product, can parents get the product directly?
Yeah, great question. So our product for term babies for at-home use is available online at evivo.com. So parents can purchase directly there or through Amazon. We also do work with pediatricians and supply them with samples so that they can talk about Evivo and recommend to their patients in the clinic. So if you have specific pediatricians that would like to have, or you would like them to have samples at their clinics, we're happy to get those shipped to specific pediatricians and provide additional information on how they can recommend in their practice. And that's all I'm seeing so far on questions. Are there other questions you're seeing, Dr. Sylvester, that haven't been addressed?
There was just one early one that I'll just reiterate for everyone's benefit from Christopher Stewart. He says that, who stated the nature of relative abundance data is that when something goes up, something else must go down. He's talking about the red and purple bars shifting in the data that Dr. Bajorek presented, both from the Nguyen study as well as her own. And I just answered, good question. Yes, studies that we've done shows that the absolute abundance also has a significant shift that mirrors the relative abundance shift. So he makes a very, very good point. And for the sake of, for the ease of presentation, the relative abundance is usually presented, but the absolute changes as well.
Mm-hmm.
Fantastic. If there are any other questions that haven't been addressed, we're happy to follow up with you offline, and we really appreciate your participation in the webinar today. Thank you so much.
Thank you.